Good evening and welcome to the Cancer Education Series, brought to you by MercyOne and Above and Beyond Cancer. The Cancer Education Series is brought to you through a grant made possible by the Iowa Cancer Consortium. My name is Chris Goodale and I'm the Executive Director of Above and Beyond Cancer, and it is my pleasure to introduce the founder of our organization, Dr. Richard Deming, who will introduce our speakers for this evening. Dr. Deming?
Great. Thanks, Chris. And thank you, everybody, for joining. We've got a triple header for you tonight. We've got three speakers, the three pharmacists. First of all, Julie Suter, who is the head of Oncology Pharmacy at Mercy. Julie and I have both been at Mercy for about 32 years, and she has taught me so much and is such a resource for our doctors and our patients as an oncology pharmacist. And along with her tonight presenting are Kristen Butler and McKenzie Magee. And Kristen and McKenzie are both from Illinois. They both went to Drake, where they last year in May of 2020 graduated with Doctors of Pharmacy. We call it a PharmD. They are now both in a one-year residency program called hospital pharmacy. And we've asked Julie and McKenzie and Kristen to talk tonight about the role of COVID vaccines and other vaccines that are of importance to cancer patients and cancer survivors. Not that having cancer was ever easy, but now with COVID, it makes things even more complex. And so we really are excited to learn more about the COVID vaccine and other vaccines that are relevant to cancer patients and their survivors. So I'm going to turn it over to our trio of pharmacists.
Thank you, Dr. Deming. First slide, please. So speaking on behalf of myself and McKenzie and Kristen, we are happy to be able to speak to you tonight, and we want to thank Dr. Deming for inviting us to be part of the Cancer Education Series. Next slide. Thank you. So I will be speaking first, and I'm going to give an overview of vaccines just in general and how they work and what the general approach for vaccinations in cancer patients and survivors would be. And when I finish, then Kristen and McKenzie will take over and talk more specifically about the COVID-19 vaccines and the recommendations for cancer patients and survivors with those. Next slide. So people with cancer may have a weakened immune system and be at increased risk for serious infections. The body's immune system is a group of cells and tissues and organs that work together to help find viruses, bacteria, anything that it thinks is foreign, and then destroy those. We use the term immunocompromised or immunosuppressed when we're trying to describe a weakened immune system. And the degree of immunosuppression or immunocompromise in cancer patients and survivors is going to depend on several things: the type of cancer, the type of treatment, and also a person's just specific health history. So for instance, we know that hematologic malignancies or the blood-based cancers, such as leukemia and lymphoma, are more likely to cause a person to be immunocompromised as compared to what we call the solid tumors, like breast cancer, lung cancer, colon cancer, and etc. Various treatments can cause different levels of immunosuppression. Corticosteroids like prednisone and dexamethasone are treatments that are fairly common, and most people have heard of these. And we know that they can cause immunosuppression in anyone, particularly when they are taken at higher doses and for longer periods of time. And we do use corticosteroids quite a bit in cancer patients and perhaps even in survivors, so they can be an important source of immunocompromise. Certain of our chemotherapies and what we call our antibody therapies can also cause immunosuppression, and they can do this in various ways, but a couple of the common things that can happen would be that chemotherapy in particular may cause a decrease in our white blood cells that normally help us fight infection. And The other therapies that affect the immune system may be affecting some of the immune cells and organs in different ways and be very important for causing immunosuppression as well. Now, hematopoietic or blood stem cell transplant patients will have varying degrees of immunosuppression, and that really depends on the type of transplant, whether these cells that were transplanted came from the patient themselves or came from a donor, and that's an important difference. Also, it depends what type of chemotherapy and or radiation therapy may have been given prior to the transplant. Some people are on immunosuppressive medications after the transplant, and we especially think about those who are on steroids and other medications to help prevent and manage graft versus host disease. You may have heard of CAR T-cell therapy, and in that type of therapy, immune cells called T cells are removed from the patient. They're sent to a lab where they're modified, and then they're transfused back into the patient. And these T cells have been modified in a way that makes them very highly active, very able to find the cancer cells in the patient's body and to attack them and destroy them. But CAR T cell patients can be at high risk for immunosuppression for a variety of reasons. One reason is that right now, CAR T cell therapy is primarily used in patients who have had a relapse. And so they've been treated with chemotherapy and other types of therapies in the past. And so they may already come into this procedure with some degree of immunocompromise. Then they receive some chemotherapy as part of this procedure. They may have side effects that require the use of immunosuppressive medications. And then CAR T cell therapy in itself can also suppress other parts of the immune system and cause us to have fewer antibodies that normally help us fight infection. Finally, just to mention surgery and radiation therapy, major surgeries can obviously be a risk for infection, but I wanted to mention splenectomy in particular, and that's the removal of the spleen, which is an important organ in our immune system. So if a person has to have their spleen removed, there's a great risk of infection, and vaccines become very important and necessary in those individuals. Radiation therapy in most people will not be a huge source of immunosuppression, simply because radiation therapy is normally just given to one part of the body and maybe doesn't cause any complications with the immune system itself. I did put pre-transplant on this slide because patients who are going to get a blood cell transplant may get radiation therapy. And if they do, it tends to be total body radiation, which can then cause more problems with the immune system. Next slide. Thank you. So there are important strategies that cancer patients and survivors can take to prevent infection. One way is just to avoid contact with germs by avoiding crowds and maybe avoid traveling to high-risk areas, particularly if you're immunocompromised. We all know it's important to perform good hand washing, and if we can't wash our hands, to use hand sanitizer, the approved hand sanitizers that are at least 60% alcohol. And I think with COVID-19 and all we've been doing in the past year, I think we're all just very up on that line of thought. We want to think about precautions to take with pet and animal care. In general, if you have a weakened immune system, it would be best not to probably clean litter boxes and clean up after your pets. You want to avoid touching feces and animal fluids. And if you don't have a weakened immune system, just in general, good hand washing is a great thing to always do. With protective gear, I think we always are thinking face masks these days because of COVID. But even when we get back to a normal non-COVID time frame, I think we always want to think about face masks as protective gear for people who have weakened immune systems. But other protective gear that can help would maybe be things that would help us to avoid cuts in the skin that might allow germs to enter the body. So perhaps if you're gardening, to wear gloves. If you like to go barefoot, maybe it's a good time to wear shoes when you're going outdoors instead of being barefoot. I mentioned on the slide antibiotics and antiviral medications. We call that prophylaxis, and we're trying to prevent infections in high-risk patients. So again, in certain situations, people may be on antibiotics to help prevent bacterial infections or antiviral medications to prevent infections caused by viruses. And then with regard to vaccinations, it is important to stay up to date with recommended vaccines when those are appropriate based on your own individual situation. And if it's safe to travel, just keep in mind that there are certain vaccinations and preventative medications that may be necessary before traveling to certain high-risk areas. One thing to keep in mind, I think, for all cancer patients and survivors is that you would always want to talk to your doctor about whether you can get vaccines and when it would be appropriate to do that. Also, however, keep in mind that your household contacts and people that you will spend a lot of time with, you would want to maybe have a discussion with your doctor about the vaccinations that they may be contemplating as well. As we'll see, there are certain vaccines that you would want your household contacts to probably avoid as well. Next slide. So let's think about how vaccines work. In short, the purpose of vaccines is to train your body to fight off germs faster, so bacteria, viruses, and we're just trying to prevent infection. So vaccines themselves are made from very small amounts of viruses or bacteria, and they are either dead or weakened forms of those viruses or bacteria. After the vaccine is given, our immune system goes into action. It's going to recognize those pieces and parts of viruses and bacteria as something foreign. The immune system is going to kick in and it's going to attack those things and learn how to fight them. An important component of this is that we have memory cells in our immune system. And so we're also teaching our body to remember that virus or the bacteria. So if we are exposed to it again, the body will recognize it quickly and be able to fight it off more quickly and prevent infection. So that's really the idea behind vaccines. And so I've introduced the idea here that we have to have a good immune system in order for vaccines to work properly and really produce that level of protection that we're looking for. Next slide. With regard to vaccinations to prevent infections in cancer patients and survivors, there are a few challenges. One is that if there is a weakening of the immune system may not be strong enough to fully respond to those vaccinations. And so the cancer patient or survivor with a weakened immune system may not be fully protected against the infection. A second challenge is that some of the vaccines are made from viruses in their live form, and these live viruses have been weakened or what we call attenuated, and normally those would not cause infection in healthy people, but they can cause infection in immunocompromised individuals. So timing is very important. In general, we would say that vaccines should be given before starting cancer treatment if possible. And if vaccines can't be given prior to cancer treatment, then we generally need to delay them until a protective immune response is more likely. So that usually means waiting for a period of some number of months after the cancer treatment has been concluded. And as we'll talk about, there is an exception, and that's the flu vaccine, which can be given during cancer treatment. Next slide. So there are a couple of different categories of vaccines, and the ones that are generally considered safe are the ones that I've just lumped into the category of inactivated vaccines. So these are made with either killed viruses or bacteria, or with pieces of viruses or bacteria, maybe a sugar or a protein that's normally part of those germs, or a particular toxoid that maybe a virus or bacteria would normally use. And so our vaccines are sourced in those ways, but these are not live vaccines in this particular column. And these are generally then considered to be safe for cancer survivors and transplant survivors. And examples of those types of vaccines are listed on the slide. So your flu vaccine that is given as a shot is considered to be generally safe. The pneumococcal vaccine is one that is it's indicated for certain people that are at high risk of a certain form of pneumonia that can be common and caused by a bacterial called pneumococcus. Shingles vaccine, there are a couple of different kinds. The one that's listed in this column, the Shingrix, is the one that is made as a non-live or as an inactivated vaccine, and it's generally considered safe for cancer and transplant survivors. There's the human papillomavirus vaccine, which is the herpes virus vaccine. Vaccines against tetanus and diphtheria are inactivated, as well as hepatitis A and B vaccines. Now, on the other side of the table, we have listed vaccines that generally need to be avoided because these are live vaccines. We call them live attenuated, which means that they've been weakened. And so normally, again, not a problem in healthy people, but in immunocompromised individuals, a live, weakened, or attenuated vaccine could grow and cause infection and be a real problem. So these examples are like the measles, mumps, and rubella vaccine, the chickenpox vaccine, the shingles vaccine that is the live version, so that's your Zostavax, and the flu vaccine that's a live version, and that's the nasal spray or the flu mist. Next slide. So really a lot of this comes down to timing. We said that all indicated vaccines should be given prior to therapy when possible. So a little bit more detail now that you know of the different kinds. The inactivated vaccines can be given at least 2 weeks prior to starting treatment. But if it's a live vaccine, it needs to be at least 4 weeks prior to starting treatment. And this is prior to chemotherapy, other immunosuppressive therapies, prior to splenectomy. Also would apply to stem cell transplant patients as long as they're not already immunocompromised before starting therapy. Now, during chemotherapy, we normally avoid giving vaccines because we could give inactivated vaccines. The flu vaccine is a great example, but most of those vaccines, if we did give them during chemotherapy, we wouldn't expect that they necessarily are able to produce that full response, that robust response that we're looking for. So generally, we're not going to be giving those. The flu vaccine is the exception. It is recommended and can be given during chemotherapy. The others will generally delay until afterwards. And then just another reminder, live vaccines should be avoided during chemotherapy. So what is that delay following therapy? Well, in non-transplant patients, after chemotherapy, we normally need to wait at least 3 months before giving vaccinations. However, some people will be on treatments that we call them anti-B cell antibodies. And the most common example is rituximab, or you may know it as Rituxan. And because B cells are part of our immune system, and a drug like rituximab and others in this category are going to interfere with how those cells are working, we do need to wait a bit longer. So anyone who has had either that therapy by itself or in combination with their chemotherapy would need to delay vaccinations for at least 6 months after finishing therapy. Next slide. So the timing following a blood or hematopoietic stem cell transplant is going to be a bit different. We need to wait a bit longer because the degree of immunosuppression tends to be very significant, and also many of these patients may be on immunosuppressive medications following their transplant. So with the inactivated or those non-live vaccines, we need to delay for at least 6 months after transplant. The flu vaccine that's given as the injection, the inactivated form, could be given as early as 4 months, but in general, with most vaccines, we're looking at 6 months or longer. The live vaccines, in general, we avoid them, and they really do need to be avoided in any transplant survivor who's considered to have a weakened immune system, and also need to be avoided in anyone who has active graft versus host disease. And that's just a common complication following transplants where the recipient received these cells from someone other than themselves, from a donor. And so oftentimes if that is going on, those patients are on immunosuppressive therapy to kind of help treat that. Now, at some point, if a person following transplant is felt to be at risk for like measles, chickenpox, some of those live vaccines, it would be a consideration after 24 months to maybe give those live vaccines in that category. But these people need to meet specific criteria. There needs to be a really expert evaluation of their immune system. And this would be under the supervision of their transplant physician and perhaps vaccination or infectious disease specialist as well. Next slide. So we'll just look at this a little bit different way now. These are specific vaccines that are generally recommended for adult cancer patients and survivors. And my next slide will show vaccines for transplant survivors. So the influenza vaccine is recommended every year. We said that it's best to get it 2 weeks prior to chemotherapy, but we can give it during chemotherapy, and that's considered to be acceptable. However, we want it to be the shot and not the nasal spray, so we're avoiding the flu mist if a patient is immunocompromised. Other vaccines that are generally recommended would be the tetanus and diphtheria, or the one that's tetanus diphtheria with acellular pertussis. The pneumococcal vaccine, we said it's a common source of pneumonia in patients who are 65 years of age and older. So that tends to be who gets pneumococcal vaccine. But you may also see it recommended for immunocompromised patients who are younger than age 65. The human papillomavirus or herpes virus vaccine may be given to adult cancer patients and survivors if they were not previously vaccinated with this particular vaccine, and if they're age 45 or younger. The shingles or zoster vaccine, in general, it's recommended at age 50. Now this is for the recombinant, the Shingrix, which is not the live version. It is recommended at age 50 and older. And the reason I say that it would only be recommended with certain criteria, I think is simply because the entity that's part of the CDC or the Centers for Disease Control and Prevention, that entity that gives the vaccine recommendation hasn't really given a recommendation about giving the zoster or shingles vaccine in patients who are moderate to severely immunocompromised. And so I think that, again, it has to just be an individual case-by-case evaluation as to the appropriateness of that. And then there may be other vaccines as indicated. Next slide. In transplant survivors in general, we'd like to see the flu vaccine, the pneumococcal vaccine, the tetanus, diphtheria, acellular pertussis, and the herpes virus vaccine. In addition to that, we're looking at these others that are listed. Haemophilus influenza type B, or the Hib vaccine, is important because that causes pneumonia in adults, and in children tends to be a source of meningitis. The meningococcal vaccine is recommended for transplant survivors, and that would help to reduce the risk of meningitis. Hepatitis A and B vaccines are generally recommended, and the polio vaccine, as long as it's the inactivated, non-live version of that vaccine. And again, we have this potential to give the zoster or shingles vaccine. The only reason the CDC maybe hasn't made a blanket recommendation to do this in immunocompromised patients is because there's just not a lot of, there's less data to support that at this point. But there is enough data that it may be recommended, again, on a case-by-case basis, and particularly maybe in the non-transplant patients and in people that are farther out from their therapy or their transplant. Next slide. This slide, I just wanted to list a few things that I thought might be really helpful. The National Comprehensive Cancer Network, or NCCN, guidelines for patients has a nice brochure on survivorship care that had some great information about vaccines. The American Cancer Society had a website about vaccinations and flu shots for persons with cancer that I thought was well done. And then the Centers for Disease Control and Prevention, if you just want to look at immunization schedules for adults in general, You can find it there, and it also would list some of the maybe contraindications or people that should avoid certain vaccines. And so that would include some information about whether or not a person with a weakened immune system could get certain vaccines. Next slide.
All right, so that transitions us. I'm not sure what the feedback is. That transitions us into our next topic, going on with the vaccines, but now we're just going to focus more on the COVID-19 vaccine. It's new and it's coming out. We're extending it to more people other than our first tier of individuals that qualified for it. So we just wanted to go ahead and walk you guys through some of the recommendations that have been made on that as well. So first, just a little bit about the SARS-CoV-19, which is the virus that causes COVID-19. So it is a strain of the coronavirus that we have now kind of adapted to just call COVID-19 in general. So the first reported incidence was in China in December 2019, and we have been continually going through this process of trying to eliminate it or get our numbers back down so that this pandemic that has been worldwide since then can go away for us. So coronaviruses are a family of viruses that can cause common colds as well as other respiratory diseases. This is not the first coronavirus that has appeared. There have been a few others. This is the only one that has caused a pandemic though. So over time, viruses can change or mutate. I'm sure that if you watch the news, you've heard about some new strains that have come out. So these new strains are variants of the virus that can have slightly different properties than the original virus. So for example, some of them may be more likely to result in infection if a person is exposed, and maybe that they're more likely to infect people, but maybe less likely to cause significant consequences than the original one. So we're still learning about some of these variants and our protection against them, as well as we'll get into a little bit of what the vaccine can do for these. So the virus spreads by droplets in the air after an infected person sneezes or coughs, and the droplets can linger on the surface and they can be transmitted when touched. So we can get this through contact as well as through like the spread of droplets in the air. So the COVID vaccine is a little bit different than the vaccines that Julie had just mentioned. This is a inactivated, not live vaccine, but the way that they have presented it in the vaccine is a little bit different than some of the other ones we're used to. So this is an mRNA vaccine, which means that the vaccine contains a small piece of engineered virus, of the virus's mRNA, which is a piece of the DNA or structure that encodes for the proteins and the receptors and other things that the virus makes in order for it to survive and replicate, things like that. So the mRNA instructs the cell in the body to make the virus's distinct spike protein, which is what we're trying to target with this vaccine. So the spike protein is a crucial part of allowing our body to react to the SARS-CoV virus, COVID-19 virus. And so when a person receives one of the vaccines, the body produces copies of the spike protein from the vaccine mRNA being incorporated and then allowing for our own cells to make copies of that spike protein. It does not cause disease, but then the spike protein triggers the immune system to learn and react defensively and produces an immune response against COVID-19. So this is the same thing that Julie was talking about earlier. We elicit an immune response so that our body can then remember the virus that causes the reaction, and then from there our bodies can respond quicker in the future. So once the immune system learns what the virus looks like, the next time it approaches the immune cells, they can respond faster and have a more robust response so that we can hopefully control the reaction or the virus infection more quickly and with a higher response. So this helps to decrease the incidence and complications from COVID-19 in general. So that's why our vaccine is so beneficial to us right now. So what COVID-19 vaccines do we actually have? So we have two that have been gone through the FDA and have been approved for use currently. Kristen's going to talk a little bit about why that's a little bit different than some of our other vaccines that are approved for use on the next slide. But the ones that we do have and have been administering include the Pfizer vaccine, which is a 2-dose series with the second dose being 21 days after the first. And then we have the Moderna vaccine, which is also a 2-dose series with the second dose being 28 days after the first. So that's really the only one of the big differences there is the time that you have to wait in between your first and second dose. There is also a Johnson & Johnson vaccine that's currently in the process of getting approved, and they're hoping that that will just be a 1-dose series for that vaccine. The Pfizer and Moderna vaccines have shown through their studies that they are roughly or more than 90% effective after getting 2 doses. Whereas I actually just saw this morning that the Johnson & Johnson vaccine came out and it's roughly 60% effective. They've studied it in different areas. So in the US, it was 72% effective, but in different areas, it was a little less effective, causing the average to go down to roughly 60 or so. The other difference between Pfizer and Moderna is that Moderna is only approved for people 18 and older, whereas Pfizer is approved for those that are 16 and older.
Alrighty, so I will take over for a few slides here. So as Kenzie had just mentioned, that our current COVID vaccines are approved under what we call a EUA. So that's an emergency use authorization. So what that means is that the FDA has approved the use of this vaccine, or in other times, a drug, during a time where there's an emergency. So right now, the pandemic qualifies the vaccines to get this approval. So from that, in order to get an EUA, the product has to prove that there are potential benefits that will outweigh the risks. So in the studies of these vaccinations, they have proved that. So the FDA has granted them an EUA. It isn't the same as a full FDA approval, where that would require more robust studies as well as longer times to study that safety and efficacy. And then being that they have given an EUA, we will continue to study these in clinical trials, which might be why in the news and stuff you will hear more information come out later about possibly dosing series, see how long we have immunity after we've gotten these vaccines. So as we learn more and are able to vaccinate more people, we can learn, again, more about these vaccines. So as I have there on my last point, we will continue learning the long-term effects of them, as well as how long we will have the protection. And an EUA for these products will last as long as it's deemed an emergency use. So from what we can say now, that these products will be approved through the pandemic. Next slide, please. Going into some adverse reactions that you might possibly have after receiving the vaccine. The biggest one will be an injection site reaction. So you could have some redness, swelling, pain in the arm, as well as a fever can happen. You'll have muscle aches as well as some fatigue. Typically, these adverse reactions only last about 24 hours. However, some people have been having reactions that have lasted longer. The second dose in the Pfizer and Moderna series have been proven to have more side effects than the first. Again, people are going to react differently, so that might not be the case for everyone. So it will be interesting to see once the Johnson & Johnson vaccine comes out if they had more side effects with that first dose. At this time, there is it isn't recommended to pre-medicate before you receive your COVID vaccine. So growing up, my mom would always give me a dose of Tylenol as a kid before going in to get my routine vaccination. So at this point, that is not recommended. However, feel free to use Tylenol or ibuprofen post your vaccine to help with that fatigue, muscle aches, as well as fever. And then another side effect that these vaccines can cause can be some swollen lymph nodes. So as our body is reacting to the vaccine. Can see for about 3 days to up to a week after the vaccine. I just kind of raised this because swollen lymph nodes can also indicate that we have our body is fighting an infection, as well as can be a screening tool we'll use to look for cancers. So if it continues after a week after the vaccine, just call your provider, set up an appointment just to make sure we're not at risk for an infection. Next slide, please. All right, so then COVID vaccine in cancer. So cancer patients generally are at an increased risk for suffering consequences of COVID, mainly due to our agents that we use to cure cancer. So for one instance, the chemotherapy drugs that we use, they're going to treat cancer by killing the fastest growing cells in our body. So this is both our cancer cells and the good cells, specifically our white blood cells. And the white blood cells are good for the body. They kind of, as Julie and Kenzie have both mentioned, are that immune system. So when we introduce chemotherapy agents, we're going to decrease our white blood cells as a consequence of the chemotherapy, and that would put us into neutropenia. And then when we have neutropenia, as you can see in that little graphic in the bottom corner there, that we just kind of have less of an immune system. So we're more at risk then for having secondary infections, as well as just being more at risk for bacterial or these viruses. As well as stem cell transplants and immunotherapy can also cause your immune system to be suppressed and then again, leaving you more at risk for infections. Another thing is that it is still kind of, how I mentioned, unknown if there's equal efficacy in the COVID vaccine in patients with active cancer or a weakened immune system as compared to a healthy individual. As of right now, it's not recommended to get an additional dose or have another series at this point. It is still recommended that 2-dose series of the Pfizer or Moderna for patients or for cancer patients. But again, as we learn more, we might learn that there will be a different regimen. Next slide.
All right. So next, I'm just going to talk through the NCCN guidelines for COVID-19 vaccines and cancer. And then Kristen's going to wrap up with just a broad overview of what should be recommended in cancer patients or survivors. So NCCN, as Julie alluded to earlier, excuse me, stands for the National Comprehensive Cancer Network. And so these are just some guidelines that they had put out. They also do guidelines for a number of other cancer related topics. So they're typically a good source that we use. So their guidelines suggest that stem cell transplant or CAR T therapy patients should wait at least 3 months after getting the transplant or therapy before getting the vaccine. So that's a kind of specific recommendation, but I would make sure that you talk to your oncologist or provider in order to make sure that they agree with the 3 months. This is typically a pretty renowned network that puts out these guidelines, and a lot of oncologists follow what they put out, but just have that conversation and make sure that you're not at risk for anything before getting the vaccine. Also, those receiving cytotoxic chemotherapy for hematologic malignancies. So as Julie had said earlier, this would be like our leukemias or our lymphomas. These patients should typically wait until they have cell count recovery post-chemotherapy. So as Kristen just alluded to, chemotherapy can knock down our white blood cell count. And so we'll want to make sure that we have a recovery in that cell count in order for our immune system to elicit a response to the vaccine that we're receiving. Another population is the surgery population. So if there is surgery planned, the vaccine, it's recommended that the vaccine should be separated from the day of surgery by a few days is what the guideline that they put out or recommendation that they put out said. And that's in order to tell whether the cause of the symptoms, such as like fever, would probably be the big one, is due to the vaccine, or if it's maybe due to an infection post-surgery, stuff like that. So they want to separate those two so that if anything happens after surgery, it can't be brushed off because you had just gotten the vaccine and it could be a response to that. Again, I think Kristen will go a little bit more into like an overview of the recommendation, but I would talk to your surgeon and they likely have some sort of time frame that they like to follow. Other than these current populations or these situations that I just listed above, the NCCN guideline didn't suggest that there was a need to wait to get the COVID-19 vaccine and any of the other populations, but Kristen also will go through a few more of those specific patient populations. So the guidelines also put out special populations that they were kind of looking at or more concerned about. And so those include populations that have additional risk factors. And they said that these patients should be prioritized in getting their COVID-19 vaccine due to the fact that they are more prone to having consequences from COVID-19 if they were infected. So those additional risk factors include people 65 or older. If you have a comorbidity such as pulmonary disease, cardiac disease, or renal disease, and then limited access to healthcare, or if you're a part of an underrepresented minority. And this has just been through the studies of the coronavirus infection that these people typically have greater consequences if they're infected. So they have that additional risk factor. It was also put out in the guidelines that the caregivers of those with cancer should also be vaccinated whenever it becomes available to them. That doesn't mean that they will necessarily be prioritized, but depending on their occupation or where they fall in the tiers of getting vaccinated, they should be able to be vaccinated whenever it becomes available, and it's actually recommended that they do in order to stop the spread or have it be less likely to pass on COVID-19 to someone that, to a cancer patient or a cancer survivor.
Alrighty, so like Ken had mentioned, we kind of gave you a lot of information of what the guidelines recommended, so I just wanted to lay it out a little bit smoother here. So for patients that are of active cancer or radiation therapy, generally, like as of today, it's recommended that we get the vaccine between cycles or after, like Ken had mentioned, that your immune system has that chance to recover, where we can have the immune response to the vaccine to hopefully give us the best protection that we can. If there is a solid tumor malignancy, receiving immunotherapy, chemotherapy, or radiation, it's generally recommended to actually get the vaccine when it is available to you. For surgery, again, like Ken said, check with your surgeon because it is case-by-case basis, and that time frame in the guidelines do say the few days, and this goes off, like Ken had mentioned, just the severity of the surgery and where that time period will be. So again, check with your surgeon. Next slide, please. And then for a survivor, active monitoring, get the vaccine again when it is available to you. And then if you are involved in a clinical trial, kind of what I found is it's generally allowed to get the vaccine because it is not a live vaccine. But again, if there are concerns, just double check who you report your findings to and ask for that.
Okay, so to wrap up with the vaccines that I discussed, as a reminder, if it's not the COVID vaccination, the guidelines were to get vaccinations at least 2 to 4 weeks before starting cancer treatment if possible, depending if it was the non-live or the live version. If not possible to get vaccinations prior to treatment, then typically they're delayed until after treatment, at least 3 to 6 months after treatment, or at least 6 months after transplant. The exception being the flu vaccine that is the shot. And then live vaccines do generally need to be avoided, particularly in immunocompromised patients, survivors, and transplant survivors.
And so we do have 2 available COVID-19 vaccines that are mRNA vaccines, and they are not live. So that goes along with some of Julie's statements up there. It is a unique vaccine though, so just be aware of that. And then in a broad statement as to who's recommended to get it and who shouldn't, really, as long as you're so active chemotherapy, as well as if you're a transplant patient or have CAR T therapy, if you're undergoing radiation or a surgery patient, you should have a discussion with your provider just to talk about timelines. The NCCN did make some recommendations, as Kristen and I went over, but just making sure that they're okay with that as well, since this is a newer vaccine that's out. Otherwise, all others should get the vaccine as it becomes available to them, based on how the states and government has their tiers lined up for who can get the vaccine at what point. And then these are just some references that Kristen and I had used in order to gather our information on the COVID-19 vaccine. So if you're interested in any of that information, you can look in there. Otherwise, that concludes our presentation.
Very good. Great. And let's see, Mackenzie, I'll have you take it off the screen, or the sharing. There we go. We'll get all of our faces back on the screen. So welcome back, everybody. That was great. Thank you. I learned a lot. What a great review of the role of vaccines in patients with cancer and cancer survivors. Maybe let's focus a little bit more on COVID. I mean, that's still on everyone's minds. Every single patient I saw in clinic today, the COVID vaccine came up. Some of the patients have had them. Some have had one shot and they just got a call that the next shot's on hold because the supply is low. And others are wanting a shot, but one is 54 years old, doesn't quite meet the age criteria yet, but has just completed cancer treatment in the last few months. And we talk about, people that are at increased risk, but yet the process that we have in place right now doesn't necessarily encourage a process by which patients younger than 65 can easily declare their risk and move to the head of the line. So lots of unanswered questions. Let me just ask you, Kristen and Mackenzie, have you helped at all with any of the vaccinations that have been going on? I know that when we healthcare workers, when I went to get my vaccine, some of the pharmacy staff were helping with the whole vaccination process. So maybe have one of you tell me, what's it like to try to draw up 6 doses of a vaccine from a tiny little vial? And from a pharmacy perspective, how difficult is this process of temperature regulation and drawing up small doses and using them before they expire and getting them in the arms and keeping track of everything? I'll just invite any one of you to comment on what you have learned about COVID vaccinations during the I guess we started in December, if I remember correctly.
I guess I'll jump in. I don't think that Kristen has either, but I'll let her speak for herself. But we actually haven't had the opportunity to try to administer vaccines to the people that have come to the hospital in order to get them, or the healthcare staff just because we jump around from different specialties every few weeks. And so it's always, our schedules get kind of crazy, and we're trying to learn as much as we can with the pandemic going on. So there's just a lot of being pulled in different directions and trying to decide, you know, how we can help. So we haven't had the opportunity to actually administer the vaccines, but just from getting our vaccine, talking to the people that have been administering, it seems like it's going fairly well, that our process is down to a T, really. It's very efficient. They get people through very quickly. And so I don't think anyone's really had to wait that long in line in order to get their shot, or even afterwards to report it to the like Iowa immunization system. So I think overall it's been good. I had a very positive experience getting my vaccine, but unfortunately I haven't been able to help administer those yet this year.
Thanks, Mackenzie. Kristen, anything else to add?
No, she pretty much hit it right there on the nail. Yeah, whatever system we have, it works very nicely. You waited in line, kind of signed your agreements. The next available person gave it to you, gave you the little spiel, and you walked out. So not much to add to what Kenzie had.
Julie, any additional comments?
Well, I liked the fact that I could opt in to report side effects if there had been any. So I was getting, text messages to prompt me to report in daily at first and then weekly. And I think that's really important because these are newer vaccines with a little bit less of that long-term information that we're accustomed to having. So I enjoy being able to do that, and certainly would encourage others to do that if they have the opportunity to opt into that.
Very good. Julie, have you been involved with any of the vaccination on patients on the floor or in the Mercy system?
I have not.
Okay, great. My experience was also very favorable when went through the process, and I think what's the most frustrating to many people is just how many phone calls you have to make. We as healthcare workers really benefited from the fact that our employer Mercy stepped up, as did the other major healthcare systems, and provided it in-house. Getting back to cancer survivors. So let's say patients are now out from their cancer treatment and are trying to remain as healthy as possible. You listed some resources that are really good because there are some vaccines that don't kick in until someone reaches a certain age. I can think of, for example, shingles and pneumonia, and many times as a cancer survivor who's been a survivor for 5 years, 10 years, gets back into the regular follow-up with primary care. Is there a need for any other consideration of age? Let's say someone was diagnosed with cancer in their 40s, early stage breast cancer, was cured of their breast cancer. Would their need for immunization for some of those age-related immunization, shingles, pneumonia, et cetera, would that change at all because of their history of cancer? And let's say they had chemotherapy as part of their regimen, but it was, a decade earlier.
I think as long as there's not a reason to think that they have ongoing immunosuppression, not on steroids and that type of thing, I don't know that there would be an indication for like the pneumococcal pneumonia vaccine. Not quite at the age yet until you hit 50 for the shingles vaccine. And I guess the only other consideration would be, if someone felt that there was a need for the herpes virus vaccine and they hadn't been vaccinated and were still younger than 45.
Okay. Let me shift a little bit and let's talk some more about HPV vaccination. So as a cancer doctor, there are 6 types of cancer that are caused by the HPV virus. And those 6 different types of cancer are cervix cancer, vaginal cancer, vulvar cancer, anal cancer, cancer of the penis, and oropharynx cancer. So of those 6, the 2 that we see most commonly are oropharynx cancer in men. So that's cancer of the tonsils and the base of tongue, and cervix cancer in women. So in the last decade, and I don't remember when the first HPV vaccine was FDA approved, but we now have the ability to prevent those 6 different types of cancers. Have any of you been involved in any of the HPV work? And I'll just leave it open. Do you want to say anything about HPV vaccinations, either the strategy, how it's used, some of the problems, pitfalls, strategies to advance that?
I don't know that I've particularly kept up on it. I know, Dr. Deming, you would be much more of an expert on this as compared to myself, but I do know that because we're starting with, younger people, it was, an awareness issue with parents, and then getting kind of that preteen son or daughter to go in. And originally people weren't sure if it should be sons as well as daughters. So hopefully a lot of that has been overcome. What's been your experience?
Yeah, I think when we first started with the vaccine, we made the mistake of talking about young women, young girls, needing to be vaccinated and not the boys, which was really not a good strategy from the point of view of immunizing the herd. And it also connected the vaccine to this idea of connecting it to sexual experience, and just created all sorts of difficulty with the communication of what it's really about, which is preventing cancer. I've seen that the strategies whereby doctors just say, we recommend this, it's voluntary. In the United States, back when we first started doing a push at Mercy Primary Care, when you look at the number of adolescents who could have been vaccinated, we were down in like 30%. And you take a country like Rwanda in Africa, their vaccination rate was like 98%. And it's simply because there wasn't this big voluntary discussion about, are you going to do it or not going to do it, and why would you do it? And it was just like, we recommend it. So this strategy that's worked well in the United States now is just for the primary care doctors and the pediatricians to just say, it's time for your vaccine, I recommend you get it. And that becomes a strategy that really increases it. And you don't have to go into detail, but I'm just curious, Kristen and McKenzie, have you been vaccinated for HPV? And do you even remember if that was a conversation with your parents and your doctor, or was it just kind of routine?
I guess I'll jump in first, but yeah, it was right before college when I got some of those final vaccines, and my provider was just like, hey, I recommend you have this. And my mom was like, yeah, sure. So we got it that day. It was pretty easy peasy lemon squeezy.
Mm-hmm.
Yeah, nothing really to add.
Yeah. So, and I know I threw you a little curveball there, but whenever I think of cancer and vaccines, that's always on the forefront, because it's actually a vaccine that prevents cancer, and pretty revolutionary.
Mm-hmm.
Chris, do we have any questions from the audience?
Well, I would invite anybody here who is watching, if they do have a question, you can use the chat or the question and answer button at the bottom of your screen. But right now, I don't see any.
Okay. Well, we are at the end of our hour, and I want to thank Julie and McKenzie and Kristen for all that information. That was great. And thanks also for providing websites, because with all the different vaccines that are out there, nobody ever remembers everything. So knowing that we have resources that we can turn to get our questions answered, I appreciate it. So Thank you so much. And I want to thank everybody for attending. Chris, you're a little frozen up right now. So I'm going to give the log off here. And I just want to let you know that if you want to watch this again or want to share this with others, this will reside on the Mercy website for you to watch as a virtual podcast anytime you'd like. And it will also go on the Above and Beyond Cancer YouTube channel for your viewing pleasure. So thanks again, Julie McKenzie and Kristen, and thanks everybody for attending, and we'll see you next week. Thanks.
Thank you, Dr. Deming.
Thank you.